or penetrating. Penetrating trauma pierces the body cavity. Blunt trauma does not pierce the body cavity. To explain this better, if a person is stabbed with a knife, that qualifies as penetrating trauma. If you're wearing a seat belt and the person had a road traffic accident, it would be blunt trauma because no instrument has pierced the body cavity, but there are multiple pressure, bruises or concussions because of the force in the road traffic accident. When there is no penetration of the body cavity, that is called blunt trauma. Most times, blunt trauma is more dangerous and fatal sometimes than penetrating trauma. So trauma is a cause for acute inflammation. Next, we have physical and chemical agents. Physical agents like temperature, heat, burns may cause acute inflammation, or cold temperatures like frostbite may cause acute inflammation. Chemical agents like toxins, poisonous substances, benzene related products, acids, alkalis, all corroding substances may cause acute inflammation. Here it is also important to mention irradiation because high wavelengths of radiation may also cause acute inflammation and harm to the body. Next, tissue necrosis. This is a special case where dead cells elaborate mediators of acute inflammation. For example, in myocardial infarction. In myocardial infarction, cells of the heart are killed because the blood supply to that part of the heart is cut off. But after the myocytes of the endocardium die, they are capable of elaborating certain mediators which cause an inflammation, an inflammatory response in the endocardium. This is an example of tissue necrosis elaborating mediators of acute inflammation. Next, you have foreign bodies like dirt, sutures, shrapnel after explosion of grenades, etc., splinters, all these foreign bodies which are substances that are not supposed to be embedded into the human body. All these, if retained, may cause an acute inflammatory response. What is important to note here is sutures. Sutures are examples of foreign bodies which cause acute inflammation. Next, you have immune reactions or hypersensitivities. These may sometimes be fatal. Hypersensitivities also cause acute inflammatory response. Let's briefly look at chemical mediators of inflammation. If you look at this chart, it tells you that there are two sources of these mediators of inflammation. One from the cell and the other from the liver. Cellular mediators either are preformed mediators in the form of secretory granules, or they may be newly synthesized or de novo synthesis of the mediators of inflammation. Preformed mediators, the most important of them are histamine, serotonin and lysosomal enzymes. Histamine is the most important of them all. It contributes to vasodilatation. The source for these mediators are mast cells, basophils, platelets. For histamine, platelets secrete serotonin, neutrophils, macrophages secrete lysosomal enzymes. De novo synthesis of mediators, that means the mediators that are produced newly, are prostaglandins, leukotrienes, platelet activating factors or PAFs, activated oxygen species, nitric oxide and cytokines. These are very important mediators in inflammation. They may be the cause for fever. They also stimulate other leukocytes to produce the subsequent inflammatory response. They also activate other macrophages to participate in killing of the noxious stimuli. Prostaglandins are produced by all leukocytes, platelets, endothelial cells. Leukotrienes are produced by all leukocytes. Platelet activating factors are produced by all leukocytes, endothelial cells. Activated oxygen species by all leukocytes. Macrophages secrete nitric oxide. Cytokines are important and they are secreted by lymphocytes. They activate macrophages and they are secreted by the the endothelial cells. The mediators from the liver are secreted in their precursor form into the plasma. That means they have to be activated. When they are secreted, they are dormant. Factor 12 or Hageman's factor, it is activated and that produces kinin system or bradykinin. This contributes to the causation of pain. Then there is coagulation of fibrinolysis system, which dissolves the clot. Fibrinolysis system dissolves the clot. This is produced after the Hageman's factor is activated. Another precursor which is formed in the plasma by the liver is complement activation. Complement is a system of proteins which have a definite role in directly attacking the noxious stimuli and they neutralize them. This is the complement complex which is activated after they are secreted in their precursor form from the liver into the plasma. Now let's look at outcomes of acute inflammation. Acute inflammation may completely resolve. This is called complete resolution. In acute inflammation, there are vascular changes, there is recruitment of neutrophils, and inflammatory mediators are elaborated. Because of injury due to infarction or tissue necrosis, infections, say particularly bacterial infections, certain toxins or chemicals, or even by trauma. All these injuries and some others cause acute inflammation, and the outcome may be 1. Complete resolution, where the clearance of the injurious stimuli occurs, the stimulus is completely taken off. The clearance of mediators and acute inflammatory cells occurs, which means these neutrophils which are recruited are taken away from this area. The mediators also are eliminated from this area. The injured cells are replaced. Normal function comes back. Normal function is restored in complete resolution of acute inflammation. The next outcome of acute inflammation may be pus formation or abscess formation. An abscess is nothing but a collection of pus. It's a localized collection of pus. What is pus? It's a rich exudate, rich in neutrophils, edema, and surrounding extravascular fluid. That is pus. So, in acute inflammation, the outcome may be formation of pus, by which this infection is walled off at this area, and this pus may resolve and it may heal by fibrosis. But this fibrosis usually entails a loss of function. Acute inflammation may directly resolve by fibrosis instead of forming pus. The second outcome of acute inflammation is fibrosis. If fibrosis has to occur, then there has been substantial parenchymal damage. These cells are incapable of regenerating themselves, and the vascular permeability has increased up to such a level where fibrinogen protein extravasates from the blood vessel, and this contributes to the formation of fibrin threads, and this leads to fibrosis. This is the second outcome of acute inflammation. Then you have acute inflammation which progresses to chronic inflammation. The reasons are particular type of infections which are persistent. For example, viral infections, chronic infections which are which do not resolve on their own. For example, sarcoidosis, tuberculosis, syphilis, etc. Persistent injury. This happens in occupational hazards, especially in people who work in coal mines or with certain inanimate substances like silica, etc., and certain autoimmune diseases. Here, the noxious stimuli persists. In all these, the noxious stimuli persists and acute inflammation progresses to chronic inflammation. Now, let's look at how complete resolution occurs at a cellular level. Let's look at the events in the complete resolution of acute inflammation. The cellular events. Number 1, the vascular permeability of the endothelial lining returns to normal. The extra fluid and proteins which constitute the edema in the extracellular tissues, this returns to the lymph. The outflow increases. The neutrophils which are harboring the noxious substances after they have phagocytized them, they undergo apoptosis or normal cell death. These tissues after apoptosis are engulfed by the macrophages. The necrotic tissue, whatever is there after destruction, forms the cellular debris, and that also is engulfed by the macrophage. These macrophages are formed from monocytes which have extravasated from the blood. They mature to form the macrophages. A certain amount of extracellular fluid and proteins undergoes pinocytosis, which means this fluid has been taken up by the macrophage. Pinocytosis means cell drinking. That is how a bit of the extracellular fluid is taken away from here. Disposal of the macrophages occurs in the reticuloendothelial system. These macrophages also have a role to play in elaboration of growth factors, where new blood vessels or angiogenesis occurs. Fibroblasts also come into the picture and repair of this tissue occurs. These are the cellular events which happen in resolution of acute inflammation. Now let's look at the different morphological patterns of acute inflammation. They vary depending on the severity of the reaction in the tissue, the type of the tissue involved, and the specific cause of the acute inflammation. The first type in the acute inflammation is serous inflammation, where there is an outpouring of serous fluid. This occurs especially in extremities and also in lining membranes. This serous fluid is derived from plasma and mesothelial cells. This is where this serous fluid is derived from. Serous fluid is nothing but an ultrafiltrate of the plasma. When serous fluid is secreted by the mesothelial cells, the site where you see this is pericardium, pleura, peritoneum. And this outpouring is termed as a effusion. This outpouring is termed as a effusion. Let's take a look at the picture. This is a H&E stain of a skin blister showing epidermis. This is from the skin of a finger. If you take a look, this is the epidermis. This layer and this layer is the epidermis. This is the dermis. Here there is a separation between epidermis and dermis by a thin layer of serous fluid. This is a blister or the collection of serous fluid. The base of this epidermis is filled with neutrophils. This shows serous inflammation. The second type of acute inflammation is the fibrinous type. This occurs when the injury is very severe or when there is an underlying procoagulant state, like in cancers. Here the vascular injury is very severe. Because of this, larger proteins may extravasate from the blood into the extravascular tissue. For example, plasma proteins like fibrinogen. These fibrinogen molecules are converted to fibrin, and during the resolution of fibrinous inflammation, two things may occur. One, it may completely resolve, or if the fibrinous exudate is very large, there is an overgrowth of fibroblasts and connective tissue cells over this fibrinous exudate. Here, fibrinous exudate is converted to scar tissue. Fibrinous exudate is converted to scar tissue by a process called organization. This occurs characteristically in lining of organs. For example, heart, the pericardium, may have a fibrinous pericarditis, or it may also occur in the meninges, that is the covering of the brain. Let's look at a histopathology picture of a fibrinous exudate in the heart, that is fibrinous pericarditis of the heart. This is a picture of fibrinous pericarditis. This is the outer layer of the heart which is opened out to show you a fibrinous, thick, viscid exudate in the inner layer of the pericardium. This is the heart, this is the pericardium. This glistening structure is the normal pericardium. This red exudate is what is the fibrinous pericarditis. In this, the histopathological picture of fibrinous exudate, here you see the cells of the pericardium which have a lot of neutrophils interspersed in this pericardium, and there is a layer of fibrin. It is light pink and it's almost like a homogeneous exudate. This is the fibrinous exudate in this pericarditis. The third type of inflammation is a suppurative inflammation. This is characterized by production of a large amount of pus. Pus or purulent discharge is